But here we have made an exception, and I am no IVF specialist, but I think there is something which poor ovarian reserve we need to know as general gynecologists, and that is where I think we can bring in some different perspectives beyond what the IVF specialist can bring.
Right.
So the poor ovarian reserve, the definition, we can define it, or the opening thoughts of this presentation would be the poor ovarian reserve. We will be using the term POR in this presentation several times, or diminished ovarian reserve, which we will be using the term DOR in this presentation several times, refers to low number of eggs in the woman's ovaries and or with poor quality of the remaining eggs which she has. So it can either be a quantitative problem or a qualitative problem or both. And that is something which poor ovarian reserve deals with. And that is something which we do see in our clinical practice from time to time. And this is what is important for us to know how to deal with it and how to really manage it. So impaired development of existing eggs, even with ART. So even if you are giving your gonadotropins and trying to stimulate the ovaries, for that still there is either there's no development of the oocyte, or there is development, but it is not adequate or is not perfect. There is a group of people in this group of poor ovarian reserve, which may conceive if given individual treatment tailored for their profile when started early. So many women will conceive, and a lot of them, and so the idea would be generally to find out what treatment to be instituted for whom, and that is something which will be helpful in trying to guide what treatment can be offered to them. So poor ovarian reserve and IVF, what we know is that these women have a poor ovarian response to ovarian stimulation. So normally in IVF, when you use gonadotropins, you would be expecting a response where a lot of follicles would be there in the ovary, but here the response is suboptimal classically, and there's a higher cycle cancellation rates, and there are lower pregnancy rates. And that is the reason why the discussion and totally an opening of a new identity of poor ovarian reserve, and it is given a very importance, a lot of importance in the ART sector. So when poor ovarian response, the terminology came up, the criteria came up, the Bologna criteria, with that what would constitute poor ovarian reserve. And there are three factors here which we have pointed out here in the slide: an advanced maternal age of more than 40, or any other risk factors for poor ovarian response. Previous poor ovarian response, where less than three or less than three oocytes have been seen with conventional stimulation of around more than 149, that's means 150 international units of FSH daily, and an abnormal ovarian reserve test. So ovarian reserve test is something which we'll be discussing a little later in this presentation. And here, if it's an abnormal test, which should be defined as the antral follicular count with less than 5 to 7, or an AMH less than 0.5 to 1.1 nanograms per ml, then we would consider that as also another poor ovarian response criteria. The 2 out of 3, that means the woman has poor ovarian response, and she may need some individualized or specialized care to get her a better chance to have a pregnancy. So this is an idea. This is a little different from the normal age-related decline in fertility, which we are accustomed to seeing. And here it is, in this graph, you can see the estimated mean number of M2 oocytes required to obtain at least one euploid blastocyst keeps on increasing with increasing age. And so the age is in the lower bar, that is the x-axis. That is the age. With the increasing age, you need more number of M2 oocytes to obtain at least one euploid blastocyst. But that's to show that your chance of conception keeps on decreasing as you increase in age, and that is very well documented. So what are the causes of poor ovarian reserve? Why do some people have poor ovarian reserve at 30? Why do some have 35? Why some do not have it at 40? And so there are different reasons. I think one of the two commonest reasons in this entire slide would be genetic mutations and idiopathic unknown reasons. These are the commonest ones which we see. If a woman has had cancer for any reason of the organ and she has received chemotherapy and radiotherapy, we would expect that to have an effect on the ovary, and that may really help. That may help us to understand why she's having a poor ovarian response. Smoking is supposed to be detrimental. Surgeries both to the ovary and the tube. So surgeries on the ovary, we will be coming to iatrogenic POR sometime later in the presentation. But generally, we have been told by our IVF colleagues over the last decade and two, from the time we have gathered more knowledge about the subject, is that we have to be very gentle with the ovaries as far as infertility is concerned, because when you are doing a laparoscopic surgery or an open surgery, it is important to understand that the follicles have to be preserved for that less amount of energy use, and we will be discussing the other things. Same for tubal surgery. Sometimes when you're doing only a self-injectomy or even a tubal ligation, you are compromising some of the blood supply to the ovary, which could be detrimental and decrease in the ovarian reserve. Then there is autoimmune diseases, where if there is antibodies in the body against other endocrine glands, then you can have also the antibodies against in some aspects of the ovary, and in that case you will have decreased ovarian reserve. That is seen and documented in some cases. Then metabolic diseases like galactosemia is also shown to have been associated with poor ovarian reserve. So coming to the testing part of poor ovarian reserve. So how do you find out what are the tests that we normally do and how do we go about with it? Just let's try to gather some importance here. So ovarian reserve tests are christened ORT. So that is the abbreviation which is used, and which also I will be using in the next few slides. So ovarian reserve tests, or ORT, are generally aimed to determine the reproductive lifespan and the approximate menopause timing. I think over the last decade or two, we have been much more aware of ovarian reserve than ever before. And I think one of the main reasons is because of the ART colleagues of ours who have made us aware that the biological clock of many Indian women is running out. And if you do not conceive early, there may be increasing chances of difficulty in conceiving later. So help in planning about a family and individualizes management. One important point is it should not be interpreted in isolation. So once you have an AMH report and you just interpret it irrespective of whatever is happening, that does not always make sense. So you cannot take that as the ultimate truth. So we'll talk about that a little later. And testing oocyte quality or competence remains poor. So you're still really testing the quantity which is left in the ovary, and that may not always be reflective of quality, and that is something which you may have difficulty in assessing. So ovarian reserve tests should ideally be offered to women at the risk of diminished ovarian reserve, and not to the low risk population. So any woman who's walking into your clinic, if she's 18, 19, 21, 25, regular cycles, you really don't need to do an ovarian reserve test. So it would be possibly reserved for people above 30, above 35, conceiving irregular cycles. You have problems of understanding what may wrong, and then you would like to have an idea about the ovarian reserve. That would possibly make more sense. Ideally needs to be sensitive, specific, and with minimal inter and intra cycle variation. So that's important. So if you can do the test anytime in the cycle and you can get the same results, then that would be most ideal, rather than having it done at a particular day or time, and that would have more variations. And of course, it has to be sensitive and specific so that you can interpret it properly. So what are the ovarian reserve tests which we have with us, or what are the ones which we have known over time? So these are the ones. There's some biochemical tests where you'll be drawing blood and you'll be checking for a basal D3 FSH, which is very commonly done still today, basal estradiol, inhibin B, and anti-Mullerian hormone, or AMH, which is possibly the commonest ovarian reserve test done today. There used to be provocative tests, the clomiphene separate challenge test, GnRH analog stimulation tests, which aren't being done anymore, or very rarely being done. So we're not discussing them here. And then there's the sonographic imaging of the antral follicular count, ovarian volume, and blood flow, of which the AFC, or the antral follicular count, has gained a lot of importance in recent times. And when we talk about ovarian reserve tests, we essentially talk about an AMH and an AFC being done. So the accuracy of ORTs, I think that's so important, that when you're doing a test, obviously you're doing it for a purpose, that you really think that this will help you to get an idea about the biological aging of the woman, the reproductive lifespan, if you would like to say, and sometimes the response that she may have to a stimulation if you want to do an ovary for a subfertility case. So accuracy is moderate to predict quantitative response and low for the qualitative aspects. So this is something which you must understand. So you cannot take, it may be a little lower AMH as something, a very strong indicator that fertility is decreasing. So that is, it may be an indicative, of course, but it's not not something where everything is lost and she will not conceive by herself. Those things may not often be true. So accuracy is moderate as far as a quantitative response is concerned. That's what we mentioned a little time ago, but low as far as the qualitative aspects is concerned. And those aren't many tests that you can do to find out the quality of the egg or the blastocyst unless the actual observation is done by the embryologist in an IVF lab. AFC and AMH have the best sensitivity and specificity, and we have known this over time. And that is, I think, one of the reasons why these are commonly done in today's gynecology practice and IVF practice. And this is giving, but even the best ORT is associated with 20 to 25% false positive results. And that is an important point to understand. And use of more than one test does not improve the performance given by a single test. So we have our experience that, and I think I'm sure that all of you have that, whenever you do an ovarian reserve test and it is low and you think that she has a less chance, you maybe discuss it with her, talk to her about, and then to your surprise, the next month she comes back pregnant, and then you think that you have, you sort of may not have got the correct picture, and then you understand that this test has false positives, and so it may not be actually the accurate representation of what was needed to be shared in the first place. So AMH, or anti-Mullerian hormone, a little bit of the physiology about it. Where does it come from? It's a glycoprotein of the transforming growth factor beta, produced by the granulosa cells of the small and large pre-antral and small antral follicles. Sorry, and this levels usually peak at 35 years and gradually decline thereafter, reaching undetectable levels a few years before menopause. So AMH levels peak at 25, gradually decline thereafter, and reaching undetectable levels a few years before menopause. It is relatively gonadotropin independent and remains relatively constant within and between menstrual cycles, as we were discussing what an ideal ovarian reserve test is. So that is AMH. You can really test it anytime in the cycle, in between cycles, and it should have more or less the same result. It declines years before a rise in FSH is seen. So the other aspect of low ovarian reserve is rising FSH and decreasing AMH, but decreasing AMH takes place earlier. So, so you can see that some years before a rise in FSH occurs, and that is very characteristic and gives it more importance. Correlates very strongly with ovarian hyperstimulation to gonadotropins, so that is important, and a poor test for prediction of pregnancy and live births after ART. That's confirmed by meta-analysis by Iliodromati et al. And Tel R et al. The assessments are done using a standard ELISA, though there are other advanced assays which are there, and the physiological variation which we know for AMH, it shows high values in polycystic ovary diseases. OCP GnRH suppression, it shows low values. Low vitamin D3 levels, smoking, race and ethnicity, ovarian surgery would all be low. Coming a little bit to antral follicular count, or AFC, Sum of follicles in both ovaries seen on ultrasound imaging during the early follicular phase. Typically, you say day 2, day 3, when she may still be having her periods, but the important thing is to count the follicles, and they are defined as those measuring between 2 to 10 millimeters on a two-dimensional plane, easy, quick, in little inter-observer variability, and compromised precision in measuring antral follicles in women with extreme of weights. So a woman who's very heavy and a woman who's very thin may have some false reports in, or the precision would not be as accurate in measuring the antral follicles. And the dependent is, of course, on the time of the cycle. The low AFC is associated with a poor ovarian response, but has a low predictability for pregnancy. Again, it may show that you have a poor ovarian response, but that doesn't mean that she will not become pregnant. So specificity of AFC for non-pregnancy predictor value varies from 64 to 98%, but sensitivity stays low at 7 to 34%. Overestimates the actual number of FSH sensitive follicles, as it also measures atretic follicles of the same size, which cannot always be distinguished. So that is the thing, the drawback of AFC. And I think that is something which we need to understand and need to take into picture. Before we come into the management of poor ovarian reserve, I think there is some dilemmas and controversies which we can try to address and try to take it through. So far we were discussing about the definitions of poor ovarian reserve, what it is about and how to identify women there, and what are the possible reasons why a woman can have poor ovarian reserve. Then we were discussing about the various amount of tests which can be done, ovarian reserve tests, and we had discussed mainly where the AMH and the antral follicular count stand out. And here we are now discussing some dilemmas and controversies in the discussion. So in our clinical practice, sometimes we have AMH and FSH done for women at an older age, who are either going through ART or going through fertility treatment. And in 1 in 5 women, there is a discordance between the AMH and FSH results. So usually you'd expect the FSH going up and the AMH coming down, and then you'll be easy to interpret that yes, this woman is having a decreased ovarian reserve, and she will possibly need more stimulation or possibly need some more management, has to be individualized into some specific protocols. But then it may not always be the same case. Like here, like in this, 20% of cases, AMH may be less than 0.8 nanogram per ml, which is concerning, but FSH is less than 10, which may be reassuring, or AMH is more than 0.8 nanogram per ml, which is reassuring, but FSH is greater than 10, which is concerning. So if the results are not matching, means if you're getting different results, then you really may have to go more with the AMH, because that is more sensitive as far as diagnosing decreased ovarian reserve is concerned. But we do get some cases like this, and that's very difficult to explain, but you understand that always all tests are not 100% accurate, and you have to go with the fallibility of the test. Discordant ORTs, it is the same to offer an intermediate dose of gonadotropins. So you can't give too much, you can't give too less, you need to go somewhere in between. Coming to the discussion of ovarian reserve tests in the general population. So if the ovarian reserve tests are so good, can we use them for women who do not have any plans of pregnancy, who do not have any plans of marriage, who possibly just has a career in front of them, who has not thought about her reproductive life or hasn't planned when she will marry, when she will have a child. So those things are not pictured. So can ORT or ovarian reserve test help a woman to assess how a biological clock, or how long she will be able to reproduce naturally, and would that be helpful if you want to do them in every woman at the age of 25 or 30? Does it work that way? So 10% of women, we know ladies undergo accelerated oocyte pool depletion. So this is something which is again either genetically determined or idiopathic, in the most common cases where there won't be a cause, but at 30, at 32, maybe you can have very low AMH, very low AFC, and you will wonder that she doesn't have any of the risk factors other than how did she come across that. So knowledge of decreased ovarian reserve will help in modifying reproductive decisions, though though it can be done, but usually it is not done because of the fallibilities of the result. It's not something which is 100% and which will exactly tell you. And though the argument is that women will be more well versed about her reproductive lifespan, but still there's a lot of studies and there's not really good evidence to suggest that you can do it at any age group and it can tell you when she is going into menopause. You can give a hint, you can get some idea, but it's not something which which will be absolutely sacrosanct. Coming a little bit to iatrogenic decreased ovarian reserve. So this discussion will be opened up when we're talking about the different causes of poor ovarian reserve. And we spoke about ovarian surgery and tubal surgery as causes. So here in iatrogenic DOR is something like, there are several instances when you're operating both laparoscopy as well as an open surgery where fertility enhancing surgeries are done. Now, most of the surgeries today are being done laparoscopically, maybe 90 to 95% as far as fertility enhancing is concerned. You need to be very cautious about the use of energy sources because it is so easy to use bipolar cautery and other energy sources, sometimes monopolar on the ovary, on near the adnexa, and that all may have a negative impact on the oocyte yield and the ovarian reserve. So we also have understood with time, when you're doing an endometrioma surgery, there's a nice chocolate cyst out there, and when you want to do cystectomy and peel off the cyst wall, then we are destroying a lot of those follicles out there. So the balance should be among peeling it off vis-a-vis recurrence. So the idea that if you don't do it, you will have a recurrence, but at the same time, when you're trying to peel off, when you're having bleeding at the base, and when again you're trying to burn it out, then you may have then you would be distracting much more follicles. So those are things which have to be balanced. But I think the laparoscopic surgeon in every aspect has to be aware that every surgical procedure done on the ovary will be resulting in a decrease of ovarian reserve. So a lot of people have started doing AMH levels before and after surgery just to tell the patient that I'm not responsible for your AMH decline. I personally do not support that opinion, but I think a lot of people do it for medical legal reasons, that nobody can blame me that the AMH has come down because of my surgery. And now that can be anybody's guess that why the AMH has come down. It may come down just because of the disease by itself, not because of the surgery. Some people say that after the surgery, AMH temporarily goes up. But again, these are all a lot of conjectures and a lot of some small clinical experiences which haven't really translated into big studies. But something is very clear that any surgery on the ovary will lead to a decreased ovarian reserve. So lap ovarian drilling, which once was very popular maybe a decade ago, has now markedly have come down. We hardly do any ovarian drilling nowadays. It's very reserved in very few cases. And I think most of our colleagues' practice would similarly be the same. There was one point of time whenever you did a laparoscopy, hysteroscopy dye test for a subfertility case, you like to do an ovarian drilling once you saw bulky ovaries or something. And now that is absolutely stopped. And I think that most of us are very cautious and aware to use the needle, don't use the hook, don't use any other things where you'll have more heat on the ovary, and use it for the limited period of time at all if you want to do drilling. But again, be much more cautious, much more judicious in your case selection when you want to do laparoscopic ovarian drilling, because that is something which will reduce the AMH levels and which will also decrease her chance of fertility. Avoiding unnecessary surgeries, that was always the case, and much more so for women who are planning a pregnancy, because any fertility, unless the surgery is enormously rewarding, you have to think twice why you're doing it for fertility enhancing. Offering alternative therapies wherever it can be done also would be one option. Then there's another discussion which again has a different angle or different flavor to it, is fertility preservation. So when you're talking about diminished ovarian reserve, there are young cancer patients who before being subjected to chemotherapy, radiotherapy, would like to do ovarian tissue cryopreservation. So that is something which is possible in a few centers. Oocyte or embryo freezing prior to chemo radio, that is possible in many centers in ART. And these are all options which can be brought up to them or must be brought to them in this day and age before they're going through cancer treatment. I think a lot of the oncologists also are aware about these things, and they counsel the patients before they go through the therapy that if whether this option is an option which they would like to go for. In prepubertal children, when a pelvic RT is required for some reason, then of course the ovarian transposition would be one surgery which can be tried or which may be done. But again, this is something again done in far few cases, but this is something which has been very clearly mentioned in the literature. Social egg freezing. There are women, a lot of, in the Western world, some in possibly in India too, who are trying to freeze their eggs early in life before they're getting involved in the relationship, before they're planning childbearing, because they want to push all that because of either financial reasons, also personal ambitions and educational purposes or personal reasons. So social egg freezing, where your eggs are secure because at 25 to 30, you've kept them in a fridge, not a fridge, in the ART center, and then you are carrying on with your life. And then at one point of time, you say, okay, now I want to have a baby, and then you take that egg out. You get your partner by that time, get his sperm, make a baby outside the body, and then either have a surrogate or have it inserted into yourself, and then go ahead. So this is social egg freezing. Again, there's a huge amount of debate and argument and things about whether it's good, whether it's bad, whether it should be done. But that's an ethical discussion, which again comes up some other time. It's not beyond the scope of this talk. Coming to ART outcome in decreased ovarian reserve, one topic, one name, terminology, which we are all nowadays very familiar with whenever the decreased ovarian response or decreased ovarian reserve or poor ovarian reserve comes up, is the Poseidon classification and the Poseidon groups. So just to try to make I think the next slide is much more clearer. So here it is, the Poseidon group. The full form is patient-oriented strategies encompassing individualized oocyte number. So here, depending on the age, depending on the AFC and AMH levels, there are different groups which have been identified, the young ones and the old ones, and the ones which adequate ovarian reserve and poor ovarian reserve. And so basically to identify one group. So just trying to put them in perspective, the group 1 is less than 35 with AFC more than 5, AMH more than 1.2, which is an adequate ovarian reserve, and this would be the good group. Then there will be the older lady, more than 35, but she also has AFC more than 5 and AMH more than 1.2. And then they have subgroups in the groups. That's group 2. Group 3 has poor ovarian reserve, where her age is less than 35, of course, but she has less than 5 antral follicles in the AFC count, and AMH is less than 1.2. And the group 4, where she's more than 35, and again, low ovarian reserve. So different women have to be handled differently, and personalize the treatment protocols is what is the moral of the story of this Poseidon group, that once you categorize them, then it will be easy for research purpose. You know what exactly to do for each group, and then you try to personalize their protocols and try to see what works best or what the evidence has shown. So coming to the last part of the talk, or another section of the last section of the talk, is on the management of poor ovarian reserve. So till now we have discussed about the definition of poor ovarian reserve, how we define the entity. We did discuss about the ovarian reserve tests. Various tests are there, and the most common ones which we use nowadays are the AMH and the AFC, and we did discuss about that. And then we came a little bit to the dilemmas and controversies, just touching on them, because we can't go into the depth because that's beyond the purview of this talk. And I think we would reserve that for ART specialists, who are the better people to discuss more intricate matters in this regard. So management of decreased ovarian reserve. So though it is frustrating, despite extensive studies and strategies. So once you know that there is a problem, you want to try to solve it, but here it's a little different because everything is not in your hands. And so different treatments and strategies have evolved over time, and a lot of research has been poured into this subject. So all the treatment essentially has been aimed at getting a higher oocyte yield, because once you get a higher oocyte yield, you'd like to, the chances of pregnancy generally you'd think would be more. So whether high dose gonadotropins works, where you're trying to really hit the ovaries much harder than the normal dose, estrogen priming, LH supplementation, luteal antagonists, and different adjuncts, oocyte donation, assisted hatching. There's a huge list of different protocols or different aspects of treatment which have been tried or planned. So I'll just try to categorize them into 2-3 parts. One is pre-IVF adjuvant therapy, which is quite popular nowadays. And a lot of us are using different adjuvants to increase the chances of to increase the chances of pregnancy in women with poor ovarian reserve. Changing in ovarian stimulation protocol. So the different stimulation protocol changes, we'll just bring that up, and laboratory aspects. So adjuvants in poor ovarian reserve, there is androgen supplementation in the form of DHEA. That's a very popular drug now, which has been used for any woman who has a low AMH. A lot of people would like to use that along with the stimulation, whatever they would like to give. Antioxidants is a very common drug used for a lot of issues, and this is no different. L-arginine, low-dose aspirin, growth hormone, a lot of things are there, but there's insufficient evidence to support the routine use of any adjuvant therapy. One of the commonest ones which we use in this box is the DHEA, but there's still not very strong evidence to say that it makes a massive difference in the outcome. Types of ovarian stimulation: GnRH agonists, GnRH antagonists, use of LH, natural cycle, modified natural cycle, dual stimulation, addition of clomiphene citrate or aromatase inhibitors to gonadotropins, which one to use, addition of low dose HCG, and modification for luteal phase. So again, insufficient evidence to support any particular intervention, either for pituitary down regulation or ovarian stimulation. So you're trying to do some down regulation with OCPs before, or GnRH analogs before starting the stimulation. There is not very much strong evidence to suggest one is particularly better than the other. So the dilemmas which one would have would be whether to use GnRH agonists or GnRH antagonists. Not very much different outcomes, but again, from center to center, some IVF specialists would claim that they're getting better results with one. The type of gonadotropin to be used for stimulation, whether you will use FSH and FSH alone, or whether you will look at HMG as an option. The starting dose of gonadotropins, which you start with 300, if you start with at least 150 or above, like the question is like, you would be possibly considering starting at a higher dose. Does that make a difference? How much does that help? So high dose gonadotropins, let's have some discussion on that. It may not be beneficial after a particular dose. So you just can't keep on increasing. After all, it's a woman's body which you're injecting the gonadotropins. You want the results, you want the ovaries to produce eggs, but at the same time, everything would have effects and side effects. So gonadotropins more than 450 international units, or a total whopping dose of more than 3,000 international units per cycle, is really questionable. So you just can't keep on whipping a whole horse trying to get more oocytes out of that poor ovary, which is not giving the desired results. So detrimental effect on the luteal endocrine milieu, and in turn, it affects endometrial receptivity. You just cannot keep on increasing the gonadotropin dose. The other lab aspects in poor ovarian reserve, whether we should do ICSI for all patients. And the reason why they're talking about that is to reduce the risk of fertilization failure. So fertilization failure can be reduced if you can do ICSI, and whether that will make a difference is something which we'll talk about. Pre-implantation genetic screening to screen the ovaries, because you have a higher chance of aneuploidy. So can you check the better ones and then put them in? Ideal time of transfer, all freeze, to continue with the all freeze policy or not. Number of embryos for transfer, how many would you like to put in depending on the age, and accumulation of vitrified embryos or oocytes. So ICSI for all, the idea is that when you're leaving the sperms and the ovaries are aged oocytes, then your chances are the aged oocytes may not get fertilized, and there you may have a problem to start with. And so the ICSI may prevent complete fertilization failure, but a similar fertilization, implantation, and pregnancy rates in women with poor ovarian reserve without a male factor. So even though you have, so that is something which has been shown. Oocyte defects is a poor responder and are not overcome by ICSI. So oocyte defects would be there even if you do ICSI, because that's not being changed. Pre-implantation genetic screening, PGS, poor ovarian reserve has a higher chance of aneuploidy, but PGS does not increase the live birth rate despite increase in implantation rates. So the live birth rate remains ultimately the same seen in this study. And how many embryos to transfer? So the general tendency would be to transfer more for an elderly woman, and so some ASRM guidelines in 2009 say 2 embryos over 30, less than 35, less than 38, 3, less than 41, 4. But again, a lot of guidelines on the single embryo transfer also is there in an Indian context. Coming to a donor oocyte, when would you consider that it may not be a good idea to continue there? A donor oocyte? Well, repeated IVF failures, predicted poor response, age more than 40, high FSH or low AMH is somewhere. But again, we don't know how high is high and how low is low. I think that's another important point where donor oocyte counseling can be done, where that may make a difference. So in conclusion, for this talk, viewers, there is no uniform definition for poor ovarian reserve. Age, AMH, and AFC are most commonly used to predict POR, and we use the Bologna's criteria, we discussed that, but most times POR is diagnosed only when subjected to ovarian stimulation. So only when you do that, you see that they're not, then only you can diagnose poor ovarian reserve. And these are just indicators, the age, AMH, and AFC, about how to go by. The clinician should decide a treatment strategy that could give a correct number of oocytes that maximize the age-related chances to find at least one euploid blastocyst. The increasing of GnRH, gonadotropin starting dose, and then type of stimulation protocol and addition of adjuvants at this point of time does not give a very improved outcome in poor ovarian reserve. So there are a lot of studies which are coming out, and a lot of adjuvants would be claiming to have beneficial effects, but I think we need to watch the space, and I think with time there will definitely be some which will have more beneficial effects than others. The role of the oocyte and embryo accumulation, PGS, needs to be assessed before routine clinical use. That is one aspect of pre-genetic screening, to find out that you're not putting in aneuploid. Aneuploidy is not a problem there. Since POR is a heterogeneous group of patients, the prognosis varies greatly and depends on the patient characteristics. And as was mentioned in this presentation, individualizing the care and individualizing treatment remains a very important aspect of trying to treat her or give her the best optimal outcome. I thank you very much for your time, and thank you for paying attention to this webinar. It is brought to you, it's an educational initiative of the Shield Healthcare called the Shield Connect. As you have seen in the video, they are the makers of DFrag, mTOR 800, and EggRich. Thank you very much.
Thank you, sir. Thank you very much for this excellent talk. Yes, sir, you have covered all the points very well. And now the forum is open for question and answer session. So we'll wait for questions in the chat box. So till then, sir, a couple of questions from my end. Sir, as far as poor ovarian women are concerned, poor ovarian reserve women are concerned, sir, are there any guidelines regarding how many IVF cycles a woman should go, or how quickly she should be advised for the donor cycle?
No, I don't think there are any guidelines as that, but I think you will have an idea as you're trying IVF where the things are going wrong. So that discussion will come up sometime after the first, not the first, possibly the second failure, and that discussion will definitely come up, and then that decision would be needed to be taken at the individual level by the clinician and by the woman herself or the partner. So I think there's no clear-cut guidelines as far as I know, but at least but that decision would come maybe after a couple of IVF failures. Definitely it will come up sometime where this donor oocyte option would definitely be brought there.
Right, sir. Thank you. Sir, I mean, last few years, are you noticing that more and more women are coming with poor ovarian reserve? I mean, is there any trend which is seen, and are there any causes there?
I think all my fellow clinicians will agree that definitely there is a trend of a poor ovarian reserve, which is increasing in the last decade, I think. And one of the reasons is we're doing much more AMH testing than we ever used to do before. So AMH testing is being done in a lot of cases, which we never used to do much. Even for polycystic ovary, a lot of people do AMH testing to see that it is high and is suggestive of the PCO. So we really don't need to do it, but some people do keep on doing it. And because of the increased awareness about the AMH levels, a lot of more testing is being done, and a lot of more diminished or decreased ovarian reserve is being picked up than before. Whether it was used to be there before, we do not know. But the other factors which we think may be involved, which is again easy to say, difficult to always assess, is environmental pollution, stress, pollutions all over the place, in your air, in your food, in your all around you. So I think those are some factors which are maybe affecting the male sperm and maybe affecting the female egg in different ways. So I think there are issues beyond what we normally see, Dr. Prachi, which would also be affecting women, and decreased ovarian reserve could be coming out from them, but it's not very clear. But we are seeing more cases, very simply speaking. I think we are seeing much more cases than anything. And also the IVF or the ART expansion over the last couple of decades. There's so many ART centers which have mushroomed all over the country, and a lot of more understanding about fertility issues in women. So you are picking up more cases than before. Same for endometriosis, same for PCO, and same for diminished ovarian reserve.
Right, sir. Thank you. So yes, the trend is increasing. So is there any particular genetic testing or genetic predisposition associated with POR? I mean, uh,
I'm not aware, but I think there may be something. But how much we can test that in a clinical setup outside the research setting, I'm not aware, because if there is something, unless it is clinically available, it's something which you can do a testing for. There would no point exactly being in a research setting. So I'm not aware, Dr. Prachi. So I will not be able to
okay,
tell.
okay, right, sir. So any woman who is diagnosed with POR at the clinic at a gynecologist center, so is she directly sent to the specialized services, or doctors prefer to give any adjuvant treatment before sending her to any specialized treatments? What's your opinion?
I think it depends a little bit on the experience of the doctor, but I think generally these women would do better in a ART center rather than in a general gynecologist clinic, because in a ART center the management would very much be catered to what exactly that would be best for her. I think early referrals would be a very common thing in this case, and I think should be recommended. Giving an adjuvant, trying out a few months or a few years, may miss out on conceiving at all with her own eggs, and then she has to go for donor ovum after a few years. So I think whenever it depends on the capability of the clinician who's picking it up in the first place. But I think in most cases she may be better managed, or better managed in a ART center. So that would be, I think, a very referring her to a specialized care place would be the most ideal way of dealing with.
Right, sir. Thank you. Sir, you also mentioned about the trend of cryopreservation. So, is there awareness? Is there as far as cryopreservation concerned, or there is some sort of scope to do various events or to increase the cryopreservation? So, your opinion, sir?
Yeah, I think from the ISAR level, as well as a lot of ART consultants and ART specialists, among the different talks that they give, among the different discussions that they have, fertility preservation is one. Also, the same discussion comes up in the oncologists also. The oncologists also, when they have various discussions, fertility preservation also is one of the discussions which the oncologists bring up from time to time. But I think there's no really merging of the two. I think the merging of the two is something which is a need of the hour, where more discussion in these lines can be like more discussions in this line can be brought up. We've heard some excellent talks on fertility preservation from orators abroad, and some work being done in pockets in the country. But again, it's not something which is which is well understood, or which is the knowledge has not spread all over. There are knowledge gaps among the specialists, and of course among the public. It's a massive gaps. Yes, we can do programs to generate thoughts and to have some brainstorming on the issue. Yes, we can have more public awareness programs on where this could be available, what can be done. But I think more than public awareness, it should start with the specialists, because everybody is not uniformly aware about the methods for fertility preservation, what is available, where it is available, what can be done. And I think so that awareness among gynecologists, specialists would be one of the first ways forward.
Right, sir. Thank you very much. So, apart from as a general gynecologist, do you want to share few tips with the doctors? I mean, diagnosis or early pickup of this women or something age-related factors.
Yeah,
Can you?
I think Dr. Prachi, we summarized it in our slides, the
Yes, sir.
discussion what we do. So the first thing is that if you pick up a low AMH in any woman, do not assume that she will not conceive. Do not assume that she will not that she will not do very well as far as fertility is concerned. It is important to do also an AFC, not look at it in isolation. Look at it together. Look at the entire picture. If you think she's a poor candidate where things may not work, she should be referred to a ART center quite early. If you keep on spending more time with her or trying out different things, you may lose valuable time, which will never come back. So I think that those are some important messages which need to be transferred early. I think the AMH testing is now very rampant, and a lot of people are testing AMH very early in a fertility treatment, which is not a very bad idea, because at least you have an idea where she stands. But if she has a low AMH, then I think we need to follow her up early, make sure we have a focus on her, and if necessary, refer her early to a ART center.
Right, sir. Thank you. Thank you very much. So I guess we have covered almost all the points and most of the points of discussion as well. So with that, I think we can say that we have completed this webinar. I don't see any additional questions in the chat box. So thank you very much. Thank you for your time and for that excellent presentation and heartfelt thanks from the Shield family. So thank you very much.
Thank you, Dr. Prachi. Thank you very much.
Thank you.
Look forward.